Mental health care has an access problem. We have strong evidence for what works, therapies and programs that can meaningfully improve people's lives. But most of these interventions were designed for a very particular setting, for a particular clinician, for a particular kind of patient interaction. They're often clunky to deliver, hard to scale, and very difficult to adapt without losing what made them effective in the first place. The gap between this works in a trial and this reaches the people who need it is where my team spends our time. I co-direct the UW Center, an NIH-funded partnership combining human-centered design and implementation science to redesign evidence-based mental health interventions to make them more usable, contextually appropriate, and more likely to actually reach people. We started this work expecting digital technology to play a big role. And in many ways it has. Colleagues here in HCD, including Julie, Neelan, Arpita, and Gary, have worked with the center to augment interventions with technology. But we've also found ourselves spending significant time on decidedly non-technological redesign. Sometimes it's as simple as the box on this patient worksheet is too small. Sometimes it's much more complex. A patient doesn't have the guidance to do a key step in an intervention, like setting a goal or ideating steps towards taking action. This can cause the clinician to take over. They might set the goal for the patient. They might pick a goal for them or do some ideation for them, and the patient loses the chance to learn something vital to their long-term success. They don't get the effect that they need. This has also forced us to think hard about what human-centered design methods are even for in this context. In pursuit of an engaging user experience, designers might optimize away the active ingredients. For example, we might redesign interfaces that let people skip the uncomfortable, the hard things that are necessary to produce change. What if human-centered design could ensure theoretically sound interventions? Peter Slovak and I developed a framework that helps bridge goals, vocabulary, and contributions between these different fields. I have a poster on it and would love to talk with you about it more. I also want to highlight PhD student Trisha Ong's poster, which tackles a really thorny question. How do you do usability testing when the thing you're evaluating is a complex health service, not a single product or interface? Her poster will change how you think about evaluation, and it applies well beyond mental health. Come find us at the posters, and we'd love to hear your questions and ideas. Thank you.